Now we can go to musculature. Any other questions for transits? The ones I mentioned, that's the one that I really particularly trigeminal and facial. I'd say the trickiest for next week is the IAM. Watch out, that's where the facial starts. And then you wind up going outside to the stylomastoid and the glissarium, ranges of 7. Historically, that's usually the trickiest one for transits. So, neck muscles. Key on the SCMs, quite obvious. Okay, and the posterior triangle area, just the edge of the traps, more just as a landmark. And then more delicate running through it, the inferior omohyoid, just a little slip, which for lecture divides the posterior triangle to the occipital and the subclavian. Just muscular identification, no triangles or areas for allowed. That's strictly for lecture. And then much more important, go in front of the SCMs, sort of key on the hyoid, right above the larynx. So we get this group of suprahyoids. Most important for us, and digs, very superficial, right under the chin. Deep to the digs, you have the mylohyoid, that hammock muscle side to side. And then go posteriorly where you have the post-digs. Big slip of muscle that actually passes the tendon to a much smaller muscle, the stylohyoid, which, let's say, don't worry about that one, key on the post-digs. Post-dig, insertion, and digs. So you're really advanced when you come to find out that there are 2 different innervations. This is considered a chewing muscle, where this is considered a facial muscle. Chewing, trigeminal, and then this facial, 7. A lot of neuromuscular confusion with the digs, posterior versus anterior. And then you go infrahyoid, the strap muscles, 4 on each side, 2 superficial. Always the most lateral is a continuation of the inferior omohyoid. The tendon underneath the SCM, and then it reflects up. So now you have superior omohyoid, always the most lateral. And then the longest one is the medial one alongside the larynx. Comes from the top of the sternum to the hyoid, sternohyoid muscle. All right. And then we have to sort of take these away so we can see the 2 deep slips underneath those 2. You can barely, there's thyrohyoid, and then sternothyroid is right there. See those much better when we cut through the 2 on top. So those are the infrahyoids that you need to know, or strap muscles as a group. So we take a better look straight on, you can see antidigs, mylohyoid, post-digs. Side, working on the hyoid. Don't have to know the actions now, we'll talk about those in lecture. And then infrahyoid, most lateral, superior omohyoid, continuation of inferior, longest sternohyoid, medial to it. So take these away. Oh, didn't want to mention platysma. Put it away there. see that a number of times. So now you cut through the sternohyoid, the superior omohyoid. Now get a much better look at this slip going to the edge of the larynx. What is the thyroid cartilage? So now it's sternothyroid. And then the tiniest slip right there, very delicate, from the thyroid to the hyoid. Now the thyrohyoid muscle. You get a little touchy of neuro. So again, the ansa cervicalis is connected with these three, but technically not the thyrohyoid. Little branch of C1, cervical 1, actually runs along with the hypoglossal nerve. It's called cranial nerve. So some will actually say they think it's connected to the hypoglossal, which it's not. Just a little nerve branch that runs along with it. So it's a little exception for that one strap muscle. For us, just consider them strap muscles, and the great controller is the ansa cervicalis, which is for lecture with that little loop. And a nice look at that omohyoid double-bellied muscle. Unlike the antig and postig, this has the same innervation. It comes from the ansa cervicalis. All right, so those are all the anterior muscles above and below the hyoid. Okay. This, just briefly, I'll not ask you about this next week, but paralleling the antigs on the outside are the geniohyoids on the inside. Very delicate, thin, paper-thin muscles. Just giving you a little action and helping to depress the mandible, anchoring into the hyoid to the genial tubercles. You almost have to really force it and say, well, you got to have to look at the inside to see that paralleling musculature. Yeah, these are the ones that parallel the antigs on the inside. Okay. That's all I want to show that. The glossal muscles, 3 of them on each side, of great importance. So the big fan-shaped muscle beneath the tongue, genioglossus, pull it out. On the side, the sheet of muscle between the tongue and the hyoid, hyoglossus, and then coming off the styloid process behind and up into the tongue, styloglossus. Pull it back a little to the side. So those are the 3 that are the big movers for the tongue. All connected to the hypoglossal cranial nerve, tongue mover. And you can hear there's the edge of the mylohyoid with the antigs on the outside. And even down below you can see sternohyoid, superior omohyoid. Good look at post-digs there, with the little tiny muscle that goes through. Stylohyoid. I always say it looks like the thread going through the eye of the needle for that tendon. But this is the big player right there, post-digs. All right? And so those aren't obviously glossals, just these are the glossals. Alright. And here I just wanted to give you another look at genioglossus, hyoglossus, styloglossus. Used to include a little slip, paladoglossus, but it's very tiny. Not a big player at all. These 3. Of course, you know why this is there. the blackout. I'm going to see it next week. I'd like to use that one for a future event. Yeah, this is just transitioning that. Facial muscles. Table in the book, 8.1, chapter 8. Let's start where it has eye. If you're looking or just organizing these, just go right down from the eye and say, well, very minor for us, the orbicularis oculi. Much more important, the elevators versus the depressors. So he's just in these two groups, sort of keying on the orbicularis oris, circling, controlling the aperture of the mouth, the rima. Well, the levators that you really should know is levator labii superioris, pulls up. Don't worry about the aliquots nasi, that's so tiny. Other one, zygomaticus, a little off to the lateral area for pulling up on the corner, smile. And then the one you have to sort of jump ahead on the lower slide here is the rhizoris. Directly dragged back from the corner of the mouth, just a little tug. Levator labii superioris, zygomaticus, rhizoris. The levator group, smilers. And then when you go back, the depressor group, really two of them. I will not bother you with mentalis, the little chin wrinkler. Say, well, depressor anguli oris or triangularis usually is preferred because of its shape. Right down from the corner of the mouth, frowning muscle, pull down the corner. And then medial to it, depressor labii inferioris, pulls down on the lower lip, the pouting muscle, pull it down a little bit. So those are the two that are really the major depressors. Triangularis, depressor labii inferioris. The platysma has some role, but that's extremely variable. So what you're actually seeing here is a little bit of a platysma coming up over the mandible. Well, I found most it just stops at the edge of the mandible. A lot, it doesn't even come up to the corner of the mouth, like you're seeing here. All platysma. A favorite name over the years, platysma, the flat one, especially when you know it's in the superficial fascia. Okay? That's as far as I really want you to bother with facial muscles. Okay? Good. Then let's just start rhizoris. Actual dissection. I just put it up going very difficult to try to find these muscles. So paper thin. Cosmetic surgeon's nightmare getting into any damaged facial muscles and trying to restore them. So very delicate. All right, so that takes care of the muscles. Now we can go deeper in. Chewing muscles, the muscles of mastication. 4 of them on each side. These I want you to be a bit more knowledgeable about as far as origins, insertions, and actions. But most of it is obvious when I actually just show you the muscle, you know, out where it starts and ends, and what it does is pretty straightforward. Temporalis, massive fan-shaped muscle, originates in the temporal fossa, fills it up, and then all narrows down to the coronoid process, where its tendinous insertion right there really well envelops the coronoid process. And then just saying, well, anterior fibers pull right up, elevate. Posterior fibers retract or retrude, pull back on the coronoid. That's pretty obvious for actions of the temporalis. Then the masseters, origin of the cheekbone, the zygoma, that's what it's there for, and then inserts all the way down the ramus. So all of this is the insertion. Short but very strong muscle. Elevation is the prime action. Yeah, a little posterior slip for retrusion to clench the teeth. Mostly just elevation. A little bit of retraction. Also keep in mind underneath the masseters, this sheet of muscle. A lot of controversy for neuromuscular components. Buccinators, right? Where is it? Chewing or facial? For the buccinators. From the second arches, they're facial muscles, even though they're right working along with the chewing muscles, controlling the vestibule and feeding the material in for chewing. So it can be confusing when you see sort of how they work, and yet they're still considered to be facial muscles, all because they come from the second arch. Which means, what nerve do you know goes to the chewing muscles? This is for lecture. First arch, always. Trigeminal, actually V3. Facial muscles, 7, all for muscles of the second arch facial. So it has a different neurological connection, 7 versus 5. Okay, then the deep ones go more internally. Best seen from underneath the medial pterygoids, which parallel the masseters, which are on the outside. Now these are on the inside, but they run vertically. Think of the mandibular fossa, pterygoid fossa. That's where they're anchored into, in between the pterygoid plates, and then insert down at the angle of the mandible on the medial side, just on the other side of the masseters. So just where you see they're elevators, pull the mandible up, and a little protrusion with these anterior fibers pulling forward, but it's slight. So a little pulling forward on the mandible. But the massive part of it is for elevation, sort of complementing the masseters, what we'll call the mandibular sling in lecture. All right, so that's medial. And then I always consider the more complex one is the lateral pterygoid, where you go from vertical to horizontal. It does have two bellies, somewhat variable. Some it's obvious, others you can't see any difference at all. Just one big massive muscle, and not that massive as well. So it's more obvious here than it actually is. But you say, well, think of the lateral pterygoid plate underneath here. That's the prime origin. There's some a little bit up in the base of the skull, the sphenoid. But don't worry about that, just lateral plate is fine. And then goes backwards to the condyle, technically the fovea, little depression underneath. So now you have the lateral pterygoid. You can see its action is primarily pulling the mandible forward. Protrusion. That's the prime protruding muscle. And then the curvature of the condyle tends to make it curve downwards. So it's also involved in depressing the mandible. It's actually the muscle you use first to open your mouth, to depress the mandible, which, as we see, is a very weak action. Muscles very tiny for depressing the mandible. It's like counting on gravity, and then really massive ones for elevating it. Pulling up and really bringing the dentition together in a very powerful action. Talk about that coordination in lecture. So those are your pterygoids, the least known of the chewing muscles. Medial, lateral, and then the good old buccinators. Facial muscles. All right, any questions for chewing muscles? Chew that up pretty well. Okay, then we can finish up with arterial pathways. For us, everything revolves around the external carotids. Here, 8 total branches, the major ones. There are some sub, but these are the primary subdivisions. And that 4 of the 8 are really testable. Okay, you can start low, superior thyroid, come up a little bit, lingual facial. There is an ascending pharyngeal. Lingual facial are the ones we're most interested in underneath there. To the tongue, up across the face, continue up. The other 2 we want to know, superficial temporal, which I consider a branch, and then the terminal part of external carotid, maxillary. For clinicians, the orodental area, this is the big player. So you say maxillary, continuation of the external carotid, dives up underneath your cheekbones, heading for the pterygomaxillary fissure. And as it does so, it sends branches down into the mandible. So you need to know the first part is called mandibular part of the maxillary artery. Continues where it's approaching the lateral pterygoids, where it's now called the pterygoid component, vascularizing the chewing muscles, and then heads into the pterygomaxillary fissure, where it now becomes the pterygopalatine part of the maxillary artery, where it now vascularizes the maxilla, all the surrounding tissues, and then even into the nasal cavity, vascularizing that entire area. So this is the one that does most of what we consider to be orodental vasculature, all from the maxillary artery. I like you to see this one, because I like to test with it, but it's also more accurate when you can see the, well, I didn't mention on the other one, but this is the superficial temporal, little thin artery vascularizing the muscles up here in the tissues. And then the maxillary, much larger, now giving you the mandibular, pterygoid, and right in here, pterygopalatine. It's also nice when you can see up underneath the chin, the submental part of the lingual, which then radiates up into the tongue, and then the facial, which crosses over the mandible, labial branches, angular branches, all vascularizing the face. These are the ones you're more interested in, the labials. So lingual underneath, facial over the top. A lot of cases they come off together. So sometimes you really don't see two separate arteries, the lingual facial trunk coming off the external carotids. So that's a more accurate depiction of the size relationship of those vascular branches. And this was just another going where see this dilating under the cheekbone, maxillary, mandibular, and here you can really see the pterygoid relationship for those, and then pterygopalatine. See pterygopalatine, and now winding up in the nasal cavity. Talk about a posterior nosebleed, press on the maxillary artery to staunch the flow. And that's what you're seeing here. The little opening is the sphenopalatine foramen, which is actually in the inside wall of the pterygopalatine fossa. We say it's more of a vascular opening than a neurological one. And that's what you're seeing are all the terminal branches of the maxillary artery vascularizing the nasal cavity. Quite extensive. But it all started out here, the maxillary artery. Latex specimen, let's see, tremendous size, at least in this individual, it's really quite large. Here, the relationship between maxillary artery versus superficial temporal. Just seeing that is a nice, accurate relationship between the size of those two vessels. That's all I want to see. And little angular branches. Trivia. This is actually where the internal carotid and the external carotid join together, right at the corner of your eye. So they say, yeah, what was internal carotid going inside the cranial ball sends little branches through the optic foramen that come out here. So you get this little tiny connection, which technically joins the external carotid with the internal carotid. It's a little angular area. That's nothing for you to really concern yourself with. And then angiography, lingual, facial, right there. And then here's maxillary, going off deep into the nasal cavity. What you would see is the mandibular part with branches into the mandible. Pterygoid would be right in here. And then as you're getting into the pterygopalatine fossa, the pterygopalatine component. So in angiography, you can really see the maxillary artery. Superficial temporal, you can't even see it at all. It's not contrasted very well at all. Okay, that's everything you should have in your mind. 25 questions. Next week, same procedure, no surprises. Get your answer sheets, we'll go through it, and then you can leave at any time as far as if you're happy with your answers. You're done for the day. All right, anything else? Okay, that's the wrap. Head and neck for this week.